Welcome to the Deep Dive. Today, we're tackling a really significant challenge in vascular health, deep vein valve reconstruction. This isn't about your run-of-the-mill vein issues. We're exploring a potential lifeline for people with the most severe chronic venous insufficiency.
Yeah, exactly. Those folks who keep getting recurring leg ulcers even after trying, well, pretty much everything else.
Right. So think of this as venturing into a highly technical, but potentially transformative area of surgery.
Exactly. We're talking cases far beyond just cosmetic concerns.
Yeah.
And the information we're drawing on today, it's straight from the expert-level chapters of Rutherford's Vascular Surgery and Endovascular Therapy.
The 10th edition, right. Specifically that chapter on deep vein valve reconstruction.
That's the one. Our goal here is really to pull out the essential knowledge from this, advanced material and make it accessible, make it understandable for you.
So our aim is to demystify the complexities of these deep vein valve problems. We'll be looking at when and why surgeons even consider reconstruction, the different techniques they might use, and importantly, what kind of results patients can realistically hope for.
Consider it your express route, sort of, to getting well-informed on a truly impactful area of vascular medicine.
Okay, sounds good. Let's start by getting a handle on just how widespread this problem actually is.
The statistics, they give us a crucial perspective here. Across the population, you might see around 15% experiencing leg swelling, edema.
Okay.
Maybe 7% could see skin discoloration, hyperpigmentation. About 1.4% have a history of healed venous ulcers.
Right.
And currently, maybe 0.7% are dealing with active venous ulcers.
So not insignificant numbers.
Not at all. But what's really important to understand is that directly fixing deep venous reflux with surgery, it's generally reserved as a final option.
A last resort, kind of.
Pretty much. It typically only comes into play after less invasive treatments for other vein issues have been tried and, well, haven't worked well enough. And even then, it's usually concentrated in specialized medical centers for patients whose symptoms are severely impacting their lives.
And it sounds like these venous ulcers are the real problem here, causing the most distress, disability, and the cost burden, too.
Absolutely. They're often the most distressing, disabling, and costly aspect. So yeah, these are the patients most likely to be considered for this kind of valve repair evaluation.
Okay. And we're talking about people where standard treatments just haven't cut it. You mentioned around 40% failure even in compliant patients.
That's right. Around 40% even in people who follow their treatment plans diligently. And it's nearly 100% for those who, for whatever reason, struggle with compliance.
Wow. And then you've got those whose superficial vein issues were treated, but ulcers still come back.
Yeah, a significant chunk, somewhere between 30% and 50%, see ulcer recurrence even after superficial and perforator treatments.
And even clearing blockages, like in the iliac veins.
Even then, yeah. After correcting iliac vein obstruction, a substantial portion, maybe 20% to 40%, don't see their ulcers heal.
So despite all these other efforts, there's still this group, a potentially large group, who might benefit from deep vein valve repair just to get those ulcers healed.
If we connect this to the bigger picture, the textbook estimates, well, even after accounting for successful conservative therapy, superficial vein treatments, iliac stenting, you're still looking at a potential range of maybe 5,000 to 24,000 patients per year.
In the U.S. alone?
In the U.S. alone, yeah.
Yeah.
Who might benefit from deep vein valve repair specifically aimed at healing those really stubborn ulcers?
But the number of surgeons doing this is quite small.
That's what's quite striking. Perhaps around 20 surgeons performing maybe 250 operations annually. It suggests a significant gap between the potential need and the available specialized expertise.
Yeah, definitely.
And it's worth remembering, while healing ulcers is a major goal, valve reconstruction might also be on the table for other really disabling symptoms caused by the venous insufficiency.
Okay, so we've got a sense of the scale who might be a candidate. Now, to understand the fix, we need the basics of the normal plumbing. Can you give us a quick tour of the main deep veins in the leg and thigh?
Certainly. Think of the major pathways, starting with the common femoral vein up in the groin.
Right.
That then branches into the femoral vein and the profunda femoris vein, the deep femoral vein running down the thigh.
Okay, femoral and profunda.
Then, as the femoral vein gets near the knee, it goes through this muscular tunnel, the adductor canal, and pops out behind the knee as the popliteal vein.
Popliteal vein behind the knee. Got it.
And below the knee, the popliteal branches out again into the anterior tibial, posterior tibial, and peroneal veins. Those run down into the calf and foot.
So quite a network. And where are they located generally?
Yeah.
Superficial, deep?
It varies. In the groin and upper thigh, they're relatively close to the surface, under skin, fat, and fascia.
Mhm.
Around the knee, like I said, the femoral vein dives deeper. The popliteal behind the knee is a bit more superficial again. Then in the calf, those tibial and peroneal veins, they're nestled deeper within the muscle compartments.
And the CEP classification we mentioned,
Yeah.
that actually names these specific veins.
Exactly, yeah. A detailed CEP classification will pinpoint which of these deep veins are affected by the patient's condition.
Okay. And the key components here, the valves themselves, what are they like?
They're fascinating, actually. They're quite thin but surprisingly strong. Made mostly of connective tissue, very little muscle.
Mm-hmm.
Most are bicuspid, two leaflets that meet to stop backflow, and they're all lined with that smooth endothelium, like all blood vessels.
And are they spread out evenly?
Not really uniformly. You find lots in the tibial and peroneal veins in the calf, maybe 3 to 12, pretty evenly spread there.
Okay.
The popliteal usually has 1 to 3, often lower down. Femoral vein in the thigh, maybe 1 to 5. There's often a reliable one just below where the profunda branches off.
And the profunda itself?
Usually has 1 to 4 valves in almost 90% of people. And interestingly, the common femoral vein, up high, actually has 1 or 2 valves in maybe 30% to 50% of people, near the groin ligament.
That's surprising. I wouldn't have expected them that high up.
Yeah, it's a common misconception.
Okay.
Valves get rarer as you go higher. External iliac, maybe 25% have one. Common iliac, usually none. So it's a very specific, important arrangement.
Okay, so that's the system working as it should. Now, let's dig into what goes wrong. What are the underlying causes, the pathology when these valves fail?
Well, the CEP classification, the EAP part for etiology, helps categorize the reasons.
Right.
But when you're thinking about repair, the absolute critical question always comes back to the condition of the valve leaflets themselves.
Are they intact enough to fix, basically?
Exactly. Are they structurally sound enough for a direct repair to restore function, or are they just too damaged or even absent, making repair impossible?
Oh.
We do see rare congenital issues, present at birth.
Like veins not forming right.
Yeah, venous aplasia where they don't develop properly, or dysplasia where they're abnormal, sometimes part of syndromes like Klippel-Trenaunay.
But that's rare. What's more common?
By far the most common is primary venous insufficiency. Here, the basic valve structure is there, but the leaflets get, well, floppy, stretched out, elongated. And the ring of tissue supporting the valve can widen, maybe due to weakness in the vein wall itself. This just stops the leaflets closing properly, leading to backflow or reflux.
And this is usually a wear and tear thing. Degenerative?
Typically, yeah, a degenerative process that tends to affect the deep veins later in life.
The textbook mentioned an overload theory for this primary type.
Ah, yes, the overload theory. It suggests that if your superficial veins aren't working right, blood pools and recirculates, increasing the volume and pressure in the deep system.
Putting extra strain on the deep valves.
Exactly. This extra volume can stretch the deep veins and eventually cause their valves to fail too. It also helps explain why sometimes treating the superficial veins can actually improve or even fix the deep vein reflux.
By taking the pressure off.
Precisely, reducing the burden on the deeper system. And it's worth noting, sometimes what looks like primary insufficiency might have a subtle underlying congenital defect only seen during surgery.
Okay. And then there's secondary venous insufficiency. That sounds like a different ballgame.
It is, yeah. Secondary insufficiency means there's a clear, identifiable cause of damage to previously normal valves,
Wow.
the most common culprit. An acute DVT, deep vein thrombosis. A blood clot.
Right.
DVT is involved in a big chunk of secondary cases, maybe 40% to 70%. The inflammation, the scarring after a clot, the vein trying to reopen, it can mess up the leaflets.
Awesome.
They can become shortened, thickened, stiff, scarred, even get little holes or stick together. The vein itself might narrow too.
So direct repair is usually off the table then?
Pretty much, yeah. In those cases, direct repair of the original valve is usually impossible. Treatment often focuses on creating a new functional valve.
How do you do that?
Well, maybe by using a healthy valve from a new by-vein system that's transposition, or transplanting one from somewhere else like the arm, or even constructing one from the patient's own tissue, or experimentally synthetics.
Are there other causes besides DVT for secondary insufficiency?
Yes, a few others. Things like traumatic arteriovenous fistulas, abnormal connections from injury, primary intravenous sarcomas, which are rare vein cancers, even long-standing congestive heart failure can contribute.
And it's not always black and white, primary versus secondary.
No, the line can be blurry sometimes. You might see evidence of both processes. And interestingly, even in veins damaged by a DVT, you might occasionally find a valve that still looks relatively okay within the scarred vessel.
But ultimately, for repair, the question is still,
Are the valve leaflets intact enough? Can a direct surgical repair potentially restore their ability to stop that backward flow? That's the key question, regardless of the initial cause.
okay, so the valves fail. What's the immediate impact on blood flow, and how does that cascade into the symptoms of chronic venous insufficiency?
The main hemodynamic issue, the main flow problem, is reflux. Blood flowing backward across the incompetent valve, especially when you're standing up.
Right. Gravity.
Exactly. Normally, your PAF models pump blood upwards with each step, squeezing the veins. Valves stop it falling back down.
But if the valves are broken?
That pump system gets disrupted. Blood flows backward, pressure builds up in the veins. That's venous hypertension. It's particularly bad in the tiny vessels, the microcirculation.
And that sustained high pressure causes the problems.
Yeah.
Swelling, skin changes, ulcers.
Precisely. Over time, that sustained high pressure is what leads to all those signs and symptoms of chronic venous insufficiency.
You mentioned a statistic earlier about ulcers and deep reflux.
Yeah, in one study looking specifically at patients with venous leg ulcers, a large majority, 73%, had deep vein reflux. Sometimes alone, sometimes with superficial or perforator issues too.
And which veins were most affected?
The femoral and popliteal veins were the most common culprits in that group, and primary valve failure was the main underlying cause.
So it really highlights the need to fix that reflux above the calf.
Absolutely. You need to correct that deep axial reflux, the backflow in the main pipes above the calf, to control that high venous pressure when the person is up and about ambulatory venous hypertension.
Now, the thigh has those two main deep veins, the femoral and the profunda femoris. How does having two pathways complicate things for repair?
It does add complexity. Because you have these parallel drains, if you only fix a valve in one, say the femoral, but there's still significant reflux in the other, the profunda.
The fix might not work overall.
Right, the overall outcome might not be great. However, if one system happens to have a good, competent valve naturally,
Then fixing the other one can be successful.
exactly, then surgically restoring function in the bad one can lead to success. There are even cases where the femoral vein is totally blocked and just fixing reflux in a dilated profunda femoris can improve things.
Interesting. And what's this gatekeeper concept?
The gatekeeper idea. If both the femoral and profunda systems are really bad, incompetent, some surgeons might focus on putting a competent valve down in the popliteal vein just below the knee.
Why there?
The thinking is a good valve at that strategic spot can help normalize the pressures down in the calf veins during exercise, sort of guarding the gate to the calf.
Makes sense. And sometimes even further down, tibial veins.
In rare cases, yeah. Surgeons have done multiple repairs on tibial valves in the calf with that same goal, improving blood return from the lower leg.
This is incredibly detailed. So how do doctors actually figure out where the problems are and if reconstruction is even an option? What does the diagnostic process look like?
It always starts with the basics, a really thorough history and a careful physical exam.
Looking for things like previous clots.
Exactly. Previous DVTs, any known clotting disorders, how much it's limiting their activity, and crucially ruling out other causes for the symptoms, especially with ulcers, things like arterial disease.
Checking pulses is key then.
Definitely. Checking foot pulses, measuring the ankle brachial index, especially in ulcer patients, to make sure poor artery flow isn't the main issue. And like we keep saying, that CEAP classification is fundamental.
Right, for staging the disease.
Yeah, defining the type and severity, guiding management, it helps everyone speak the same language about the problem.
And who typically ends up being considered for this kind of deep valve surgery? Which CEAP classes?
Generally, it's patients in the more advanced categories, C4B, that's significant skin changes, C5 healed ulcers, or C6 active ulcers.
Okay.
It can also be considered for C3, which is really debilitating swelling, edema.
And there are ways to measure how bad it is objectively.
Yes, tools like the Venous Clinical Severity Score help quantify the disease severity. And quality of life questionnaires assess the impact on the patient's life. Using these is really considered best practice now.
So after the history and exam, what non-invasive tests come next?
A complete venous duplex ultrasound is the next crucial step. Essential, really.
That's the sound wave imaging.
Exactly. It images the veins and checks blood flow direction and speed. You really need this before any intervention,
Why is it so important?
because it clarifies the extent, the location of the problems, gives clues about the cause, primary, secondary, and the main issue, is it reflux, obstruction, or both?
Can it actually see the valves not working?
Sometimes, yeah. In primary incompetence, you might see the leaflets fluttering or just not closing right.
And how is reflux defined on ultrasound?
Usually by how long the backward flow lasts after you squeeze the calf or do some other maneuver. Typically 1 second or more in the femoropopliteal veins, half a second or more in the deep femoral or tibial veins.
And blockages, how do they look?
Obstruction might show up as thickened veins or valves, sluggish flow, maybe less response when you squeeze the calf.
What about plethysmography? Where does that fit in?
Plethysmography is another non-invasive test. It helps quantify the overall impact of the deep venous insufficiency, often used before and after repair to see how effective the treatment was. More common in advanced cases or for research.
What does it measure?
Air plethysmography gives you numbers like the venous filling index, how quickly blood pools.
Higher's worse.
Generally, yeah. A value over 2 millisecond is abnormal. It also measures residual volume fraction related to standing pressure and ejection fraction, which reflects how well that calf muscle pump is working.
So useful objective data.
Very useful. And there's some research suggesting it might help assess the impact of iliac vein blockages, too.
Are more invasive tests ever needed?
Yes. For surgical candidates, venography can be really helpful for detailed planning if the ultrasound isn't quite clear enough.
Injecting dye.
Exactly. Ascending venography, injecting dye in the foot and watching it go up, defines the deep vein anatomy precisely and rules out blockages. Vital if you're thinking about transplantation to find the healthiest vein segment.
And descending venography. That sounds like it looks directly at valve function.
It does. Dye is injected higher up, and you watch it flow downwards to see the valve leaflets, check if they close, see how much reflux there is in different veins.
Is it the gold standard?
Well, direct inspection during surgery is probably the ultimate gold standard. But descending venography has limitations. Combining duplex ultrasound and descending venography gives the best preoperative picture of the valve architecture currently.
What about IVUS, MRI, CT?
Intravascular ultrasound, IVUS, is great for assessing blockages, especially in the iliac veins. MRI and CT are generally more for looking at occlusive disease or external compression, particularly higher up in the iliacs and vena cava, usually reserved for more complex cases.
So it's a step-by-step process, starting simple, getting more complex if needed, all guided by that CEA framework.
That's a good way to put it. Clinical picture, non-invasive tests, maybe invasive studies, all to pinpoint the problem. Valvular reconstruction comes into play when superficial issues and proximal blockages are sorted, and deep axial reflux is clearly the main driver of severe symptoms.
Got it. Okay, we've identified the problem, the patient. Now, how do surgeons decide if reconstruction is the right path? What goes into treatment selection?
Right. The absolute key thing is these patients have usually failed all the other standard treatments. That's the starting point.
They've tried compression, maybe superficial vein treatments.
Exactly. And current guidelines suggest that for selected patients with advanced disease, C4B, C5, C6 surgical valve repair techniques, well, they can help heal ulcers and prevent recurrence, especially combined with ongoing compression therapy.
So it's an option for that specific group. What about patient risk?
Standard surgical risk assessment applies. They need acceptable heart and lung function. The surgery can be long and complex, so general anesthesia is typical. Any active infection needs clearing first.
And other contributing factors.
Yeah, you need to address other things, pushing up venous pressure, significant obesity, heart failure, anything pressing on the veins externally.
Are there things that make surgery less advisable? Contraindications?
Relative ones, yes. Systemic diseases that impair healing, like poorly controlled diabetes, collagen vascular disease, chronic kidney issues, significant peripheral artery disease. These need careful optimization before surgery is considered.
Okay, now the actual surgical options. How does the choice get made? You mentioned leaflet integrity is key.
Absolutely critical. It really boils down to, are the valve cusps preserved or are they absent or irreparable?
So if the cusps are preserved, what are the choices?
Then you're looking at things like external banding, external valvuloplasty, or internal valvuloplasty.
Okay, break those down. Banding.
External banding is for more limited issues, maybe just some vein wall dilation, mild cusp prolapse. You basically put a wrap around the outside of the vein and tighten it gently until the valve works. might be enough if the valve almost normalizes during surgery.
And external valvuloplasty.
That's for more significant dilation and prolapse. It involves placing sutures on the outside of the vein to tighten it up and reef the cusps a bit without actually opening the vein.
And internal valvuloplasty.
That's often considered the most definitive for extensive prolapse and dilation. You open the vein and directly shorten or reshape the leaflets themselves. The surgeon's experience often guides the choice, but internal allows the most direct fix.
Okay. Now, what if the leaflets are not okay? No identifiable structure.
Then you need a different plan. Options include transposition. If there's a parallel competent valve nearby, you can reroute the flow to.
Like borrowing a good valve's function.
Exactly. Or transplantation, taking a healthy valve from somewhere else, like the arm, and putting it in the leg vein.
Okay.
And then there are substitute valves, trying to create a new valve, often using the patient's own vein wall tissue. That technique of shaving the vein wall to make leaflets is gaining some support.
What about synthetic valves?
Most synthetic attempts haven't worked out long-term, though there is one current study with an operatively placed synthetic femoral valve showing some acceptable early results. Still early days, though.
Yeah, fixing multiple valves. Is that better?
There's some thinking that repairing multiple valves in the same main system might improve outcomes, but many surgeons report success fixing just the key single valve per incompetent system.
When doing a direct repair on an intact valve, where do surgeons usually target? Proximal femoral? Profunda?
Often, yes. The proximal femoral or profunda valves are preferred if the disease is isolated there, or if both are involved.
Lie there.
It's partly ease of access surgically in the groin. The valves are fairly consistent there, surgeons are familiar with it, and the veins are bigger, which helps technically.
But other locations are possible.
Oh yes, more distal femoral, popliteal, even tibial repairs are possible if the valves are accessible and intact. Just technically harder as things get smaller. And remember, the popliteal gatekeeper option if both femoral systems are bad.
Right. And for transposition, you absolutely need that nearby competent valve.
Correct. In the femoral profunda or even the great saphenous vein to reroute the flow below it.
And transplantation requires a good donor valve.
Yes, usually from the axillary or brachial vein in the arm, or maybe saphenous veins. And you want to implant it in the least damaged part of the recipient leg vein to minimize downstream reflux.
So lots of factors go into choosing the best technique and location.
Definitely. Preoperative imaging, expected long-term success, operative difficulty, risk versus benefit for that specific patient. It's a complex decision.
Okay, let's get into the nitty-gritty. The surgical techniques themselves. How are these reconstructions actually done? Perioperative stuff first.
Sure. Standard practice includes prophylactic antibiotics, like a first-gen cephalosporin. Intraoperative heparin, a blood thinner, is common, usually 2,000 to 10,000 units, often not reversed. And like we said, general anesthesia is typical.
Okay. And getting access. The exposure.
For the proximal femoral veins, it's usually a standard groin incision along the vessels. This exposes the first couple of femoral valves and the profunda takeoff. If you need to go further down the profunda, you might dissect under the sartorius muscle. Once you've exposed the target valve area, sometimes that strip test is done to check competence before you start the repair.
Right. And this incision works for other techniques too.
Yeah, the same groin incision can be used for transposition, transplantation, or creating a neovalve. A really crucial step is careful dissection of the vein's outer layer, the adventitia.
Why is it so important?
To precisely identify where the valve leaflets attach to the vein wall. These attachment lines are landmarks for making the incision into the vein, the venotomy, safely in confirming a repairable valve is there. If you don't see those lines, the valve might be destroyed.
And for lower down, popliteal, tibial.
More distal exposures, medial approaches, similar to accessing the arteries in those areas. For the popliteal, behind the knee, an S-shaped incision is often used to minimize scar contracture later.
Okay, let's talk specific repairs. Internal valvuloplasty first, opening the vein.
Right. It's an open technique. You make the venotomy over or near the valve. Then, under direct view, you tighten the floppy leaflets by taking little tucks, reefing them with fine polypropylene sutures like 6-0 or 7-0.
And different ways to make that initial cut in the vein.
Yeah, various venotomies have been described over the years. Kistner's original was longitudinal through the commissure. Raju preferred a transverse cut above the valve. Sokurai used a T-shape. Tripathi and Katanides had a trapdoor approach.
But the goal is the same.
Essentially, yes. Regardless of the cut, you're carefully suturing the redundant leaflet tissue to restore competence. Placating maybe 20% of the leaflet length often does the trick.
Now, external valvuloplasty. This avoids opening the vein.
Correct, that's the main advantage. Kistner also pioneered this. You place sutures through the vein wall, right at the valve attachment lines. Tying them reduces the commissural angle and vein diameter, letting the leaflets meet better.
Can be done front and back with a camera.
Yes. Anterior and/or posterior aplastication, sometimes guided by angioscopy inside the vein. Roger really stressed identifying those attachment lines externally first. There's also transcommissural valvuloplasty with oblique sutures across the commissure.
And a limited version.
Yeah, limited anterior application just focuses on the front commissure. Often done for the proximal femoral valve, sometimes with saphenous stripping.
Okay. External banding sounds even simpler conceptually.
Conceptually, maybe. You wrap a synthetic or biological sleeve around the vein at the valve site, tighten it until the valve works, then anchor it. There's even a spiral device alternative.
Is it combined with valvuloplasty sometimes?
There's debate about whether adding a band after valvuloplasty helps prevent future dilation. And there's that unusual technique of banding a valveless popliteal segment, reducing its size, but results are hard to interpret because it was done with other procedures.
Got it. Now, transposition and transplantation, moving valves around.
Right, transposition. Moving the incompetent vein system downstream of a competent neighbor, like attaching the incompetent femoral below a good profundo or saphenous valve, or vice versa. Techniques exist to handle size mismatches.
And transplantation, bringing a valve from elsewhere.
Yeah, Taheri first described taking a 2-3 centimeter segment from an arm vein with a good valve, or one you can repair on the bench. Saphenous veins are also options.
And implanting it where?
Usually in the femoral vein just below the profunda junction. You take out a diseased segment, sew the donor segment in, often do the top connection first to check competence. Interrupted sutures are key to avoid narrowing.
And sometimes the donor valve needs fixing too.
Yeah, maybe 40% of axillary valves might need a quick bench repair, like a valvuloplasty, before implanting. So surgeons often look for a naturally perfect donor valve first. Transplantation lower down, like the popliteal, is also possible.
Okay, finally, creating new valves to substitute valves. You said synthetics mostly failed?
Historically, yes, in trials. Percutaneous attempts haven't had long-term success either. But that one synthetic valve study is ongoing and some experimental work continues, like vein invagination.
What about using the patient's own tissue? Autogenous substitutes.
These have had relatively better success in smaller series. You take a piece of vein wall, fashion it into cusps, suture it into the recipient vein.
Any specific techniques?
Plagniol's technique involves invaginating a saphenous stump into the femoral vein. Moletti's technique dissects new cusps from the inner layers of a thickened post-thrombotic vein wall, quite intricate. They've improved it recently with sutures to hold the cusps semi-open.
Sounds complex.
It is. Opie described another method, invaginating a flap of vein wall to make a monocuspid valve, patching the hole. It's reportedly worked well in some places. These techniques are often fallbacks when other options aren't feasible.
And after all this complex surgery, what's the immediate post-op management?
Pneumatic compression devices are common, reducing swelling and DVT risk, maybe boosting flow through the repair. Wound drains might be used due to anticoagulation.
Anticoagulation is standard.
Long-term, maybe 3 to 6 months of oral anticoagulation warfarin historically. Now often direct oral anticoagulants is recommended after open venotomy procedures. And long-term compression support is encouraged, though compliance can be tough.
Okay, the moment of truth. What are the results? Let's start with complications and initial outcomes.
The really good news is mortality is essentially 0 in reported series, and serious systemic issues are rare, less than 1%. Local problems are more common, but usually manageable.
Like bruising or fluid collection.
Exactly. Hematoma or seroma can occur maybe up to 15%, varies with anticoagulation. Wound infections are relatively low, 1% to 7%.
What are DVT? Blood clots.
Clinical DVT rates are usually under 10% and often not right at the repair site, though one review did find higher rates after repair for post-thrombotic limbs compared to primary insufficiency limbs, around 25% versus 7%.
So anticoagulation is more critical in those post-thrombotic cases.
It seems so, yeah. If a significant DVT happens, clot-busting therapy might help salvage the repair. Pulmonary embolism is fortunately rare.
And how well do the repairs work initially? Patency, competence?
Generally excellent right after surgery. Early failure where the valve stops working quickly is rare, less than 1% in most series. Damaging the leaflets during surgery is also rare, but if repaired intraoperatively, results can still be decent.
Okay, what about the long haul? How do these repairs hold up over years? Let's go technique by technique. Internal valvuloplasty.
Kistner's long-term data showed sustained clinical success. Compilations confirm excellent results for really tough symptoms. Most series report valve competence rates around 60–70% at 5 years. If the valve stays patent and competent, patients generally do well clinically.
Makes sense. External valvuloplasty.
Potentially less durable than internal, maybe. Many studies involve multiple repairs per limb, making direct comparison tricky. Some studies show around 60–70% competence or clinical improvement at 3 years. Others report lower rates, maybe 30–50% competence or ulcer-free rates at 2 years.
So a bit more variable.
Seems that way. Randomized trials comparing it with superficial ablation were inconclusive due to study limitations.
External banding.
Acceptable results in selected patients, maybe with less advanced disease. One series linked better long-term ulcer healing to banding more valves, one valve 51% to 65%, 86%. Another group focusing just on the proximal femoral reported 78% competence and relief long-term.
Valve transposition. Moving veins around.
Good clinical results in maybe 40–50% at 5 years, including ulcer patients. One specific technique showed 55% ulcer-free at 10 years. So reasonably durable for some.
And transplantation, bringing valves from the arm.
Clinical improvement in about half the patients, even out to 8 years. Using saphenous veins as donors showed similar results at 3 and 7 years. So, again, works well for a significant portion.
How about those substitute valves? Creating new ones.
Plagnol's type showed good early patency competence. Miletti's neovalve, especially the modified version, has shown impressive results. High patency, competence, and ulcer healing rates, like 80–90% healing, though competence might drop slightly over longer follow-up, maybe to around 70%.
And OP's technique.
OP reported no incompetence at 4 years in a small group, excellent clinical improvement. Other series using substitute techniques showed decent cumulative success, maybe 70–80% clinical success and competence long-term. They're valuable when other options fail intraoperatively.
You mentioned multi-level reconstruction earlier. Does fixing more than one valve really help?
There's growing evidence suggesting it might, yes. Raju's group strongly advocates for it. Their data showed better valve competence and ulcer healing at 2 years with multi-level versus single-level repairs for both valvuloplasty and transplantation.
So potentially better outcomes.
Potentially, yeah. Others have suggested improved clinical results with multi-level external valvuloplasty or banding too, though maybe not always statistically significant. It seems logical that addressing more points of reflux could be beneficial.
What about redoing the surgery if the first one fails? Reoperation.
Can be difficult, technically challenging due to scarring. The best approach is often a new incision away from the old one, maybe accessing the midfemoral vein. Some surgeons avoid redoing popliteal repairs because dissection can be tough there.
And finally, long-term follow-up. How are patients monitored?
Typical follow-up involves exams and venous duplex ultrasound at intervals, maybe 6 weeks, 3 to 9 months, then annually. The timing varies.
Yeah.
Duplex checks patency and competence.
Have ultrasounds replace venography for follow-up?
Mostly, yes. Most surgeons also include some hemodynamic assessment, track symptoms like pain and swelling, and using CEAP, severity scores, and quality of life tools is encouraged to objectively measure success over time.
This has been an incredibly thorough, really fascinating deep dive into a complex area. Let's try and summarize the key takeaways.
Okay. In essence, deep venous valvular reconstruction is, well, it's a complex field within vascular surgery. It offers various options for people with really severe chronic venous insufficiency.
Right, the ones who failed other treatments.
Exactly. While the procedures are definitely technically challenging, they hold significant potential for symptom relief and ulcer healing in those carefully selected patients. But long-term success isn't guaranteed. It varies by technique, patient factors, the underlying cause.
And it's clearly a field that's still evolving.
Absolutely. We need ongoing research, better understanding of the disease, better diagnostics, good comparative studies focusing on patient outcomes to really push the field forward.
So here's a final thought for you to mull over. Given the complexity, the range of techniques, the variable outcomes, what are the really key ethical or practical considerations when deciding who is the right candidate for these advanced surgical procedures and when? Something to think about. Thank you for joining us for this deep dive.